It's about a 20-year-old patient with keratoconus. He had intraocular segment implantation and cross-linking in both eyes a couple of years ago. And he presented with pain, redness, blurry vision in his left eye. So his vision was 624, and this was his refraction in his left eye. Now, on slit lamp examination, we observed that the superior ring had extruded. However, there were no signs of infection, and we could see that there was a marked fibrosis in the intrastromal implantation channel in the cornea. Kmax was 55.3, thinnest point 448. So the first question, what would you do? Reimplant the ring or explant it? Anterior segment OCT showed that, first of all, two things. The ring was implanted upside down. So this is down and this is up. Okay? Second thing, the ring was implanted relatively superficial. We normally implant rings, according to the nomograms that we use, has to be implanted in 80% depth of the implantation site. So as you can see here, the ring was superficially implanted, and the combination of the superficial implantation and the eye rubbing of the patient caused the problem that you see. So now that you have more information, what would you do? Reimplant or explant? So, no answers to the question. So what I did, I explanted the ring. And the clinical course was the following. So he had prophylactic treatment with moxifloxacin, fluorometholone drops. 1 week post-explantation, patient had no symptoms at all. 4 weeks after explantation, patient was doing fine. And the question is now, what are we doing next? Reimplant, redo a ring implantation, PRK with cross-linking, PTK with cross-linking, whatever surface ablation with cross-linking, DALK or something else. So it's not fair not to give you this data from the pentacam. So the vision was 612 with contact lenses 695, 4 weeks after explantation. And this was the refraction. And the Kmax was basically the same. So from 55.3 to 55, so half diopter increase, but so stable keratometric readings, and good thinnest point, 451. Now that you have this data, what would you do? Again. So I thought...
I would do nothing at all.
Nothing at all, okay. So what is the fact?
If he's happy with that, why mess with such a high-risk cornea?
Yeah. So the fact is that the patient has stable keratometric readings and decent vision with contact lens. So I asked the patient, are you happy with your contact lens vision? And the patient was happy. So we decided to wait. We waited. He never came back, but his ophthalmologist sent us after 6 months this pentacam data. So the patient has a lens-corrected vision of 695, stable keratometric readings, and he was happy. So the case was closed. What do I want to emphasize on? First, we have some additional infos about rings. So rings could be effective, actually, when implanted upside down. So it seems that the theory that the rings are working mainly because of the tissue addition is correct. So, shall we explain this? There are two theories about the function of the ring. So one is that they work as an space element within the fibrin the fibrils of the cornea tissue, and the second is that the barrier theory, that we just add tissue to the ectatic cornea. So that's one thing. The second thing, what happens if we implant the ring superficially and the patient rubs his eye? We end up with extrusion. And the third most important thing is that even if we explant the rings, it seems that some of the keratometric effect of this beneficial keratometric effect is being preserved. Presumably, and this is my assumption, our assumption, because of the fibrosis in the stromal channel. So would be a solution just to induce fibrosis without ring implantation? So this is food for discussion. Now, the most important, and I feel this is the message that I would like to pass to every aspiring refractive surgeon, is that we should not let our patient's needs guide us. We should let our patient needs guide us and not our enthusiasm, because after all, in refractive surgery, it's all about fulfilling the expectation and the needs of the patient, but at the same time, managing the risk and playing in a safe zone. So sometimes, just like Dimitri said, less is more. Thank you.
I want to make a small comment on this case. First of all, the age of the patient. She was 20 years old. Or no? This is? I'm very reluctant in very young patients implanting rings, because there are two things. First of all, I must be sure that the conus is not progressing, because I don't think I offer much if I implant a ring in a progressive conus. The fact that you did a cross-linking does not keep us safe from the progression of the conus. We should be really convinced on that. What's your comment on that?
So, patient was treated elsewhere, and he ended up in our clinic actually for this emergency. Okay. Now, what is my personal schema or treatment approach in these patients? Progression of the disease is not relevant, in my opinion, in cases of ring implantation combined with cross-linking. So if I have a patient who's a good candidate for ring implantation in terms of visual improvement, I will implant the rings and then I will perform cross-linking procedure, because there is long-term, we have long-term results on that. We achieve stability in almost every patient. So the progression of the, I don't even bother to send for another consultation in 4 or 6 months to see if there is progression of the disease. Patients with keratoconus who are desperate to see better and good candidates for rings, they will have a ring implantation with cross-linking, and the progression issue is just gone from the table.
I think we have to consider that in your case there were some fibrosis at the area of the ring.
Which I see in most of the patients after ring implantation.
Exactly, and this fibrosis also plays an important role in the whole treatment, or the whole stability of the treatment that we see. So part of it might be the fibrosis, which is important. Part of it may be the additive effect that the ring has. And in this particular ring, because I'm not talking about Intacs. Intacs, I don't think they have the same effect as that was Kera ring. That was Kera ring. Kera ring is a different story. I think. Yeah, we should exclude Intacs from our discussion, I think, from now on, because Kera ring shows an effect.
Do you see more fibrosis with femtosecond created channels versus the mechanical old technique?
Actually, we are only doing femtosecond channels, so I don't have experience with mechanical ring implantation. Okay. But I would expect to have more fibrosis in the mechanical.
Okay, so this brings us to the conclusion of the morning sessions. We break for lunch. There will be a buffet just outside this room. The speakers And whoever has put his name down for the lunch with the expert, they can go upstairs directly to the restaurant, or there will be a setup with tables. We'll see you in 2 o'clock.